I want to talk about some complex case examples just to give an idea of how PDA can present and how different interventions that we all know and use regularly can be modified before we talk about other modifications. I'll start with, we have S. S was 3 at intake. They have a diagnosis of autism spectrum disorder level 1. They have a suspected diagnosis of ADHD. There is extreme food refusal. They presented with a distended abdomen, stunted growth, and enlarged head. They had a gastro consult. They failed Kennedy Krieger's feeding clinic as well as one other feeding clinic. Their diet consisted of 2 bottles of Pediasure a day and spaghetti noodles that were cooked without sauce, not high protein, just regular spaghetti noodles. They do vocalize in sentences, but they did not have word comprehension, which limited their independent generalization to compose more expressive vocabulary. They very much were at intake with me. It was understood that they came from a center-based program where they were forced to communicate in sentences, but really did not have an understanding of what words within those sentences meant. So everything was like, I want blank. But they didn't understand that want was actually a word that we use to access needs, desires. Then we have O. O was 14 at intake. O is blind, deaf, has trisomy 13, and severe intellectual disabilities, among some other physiological deficits. They were reported to having extreme behaviors out of nowhere. Staff had quit. They'd had left sessions with them bloody. They had broken a TV, multiple iPads. They'd left holes in the wall. They do have compliance and cooperation with staff and medical appointments and medical equipment necessary for quality of life. But at the time of intake, it was very intermittent and could escalate into extreme behavior. And when I say medical equipment, I'm talking about like a pulse oximeter, a CPAP machine, mobility aids, vision aids, communication aids. Their communication topography was minimal vocalizations and modified sign. We have Y, who was 5 at intake. They had a diagnosis of autism spectrum disorder, ADHD. They're considered gifted intellectually. They have refusal and explosive behavior out of nowhere. They began engaging in self-injury with repetitive face smacking and pinching of themselves and others. Their communication topography was precocious vocalizations with long vocal sentences in more of a rote or fixed repertoire. So again, really struggling with novel expression. We had C, who was 18 at intake. Diagnosis of autism spectrum disorder, ADHD, epilepsy, and moderate intellectual disabilities. Again, explosive behavior out of nowhere. There was at one point refusal to leave home, including medical appointments, preferred leisure activities with preferred people, and property destruction resulting in broken doors, iPads, wooden bed frames, broken bones, communication topography, minimally vocal, some selective mutism suspected, although they would text on an augmentative communication device or their phone. And then we have F, who's 26 at intake. Their diagnoses are Down syndrome, autism spectrum disorder with a moderate level, severe intellectual disabilities. They engaged in ritualistic behaviors, which led to an OCD diagnosis. And it was impacting their ability to complete all daily activities with quality of life. They had the potential for aggression, which was unsafe due to their physical size, and their communication topography is some sounds. They have some augmentative communication, but they're not initiating use, even though they had exposure and instruction with that for many years. Sorry. With S, who had the extreme food refusal, one of the focuses on therapeutic intervention was for functional communication and food acceptance. These were socially valid to the family and S and necessary to avoid hospitalization. We worked on pairing, shaping, and manned training. So we worked on really building, SBT was used, but because there was some self-injury present, but it was not related to food presentation at onset. But we did work on functional communication response. We also had to work on extended periods of pairing that food environment so that the table where food was presented with nothing but positive associations when staff members were present, and then slowly shaping over time with the caregiver focus was on education. BST was used to provide education on not only communication, but being able to present a accommodated environment to them and pair with reinforcement so that they could develop positive associations and a positive reinforcement history with food and food related environments. And then we worked on the balance program to increase relationship and positive interactions with caregivers. With O, who was 14 and had severe aggression, we worked on advocacy skills, man training, and SBT for tolerance of demand presentation. Caregiver focus was on training on providing opportunities for autonomy, adjusting expectations, how we frame demands, and then honoring and reinforcing requests, reading escalation cues. So that intensity, those demand or that escalation that was previously reported as coming out of nowhere, the explosive behaviors coming out of nowhere, there were very nuanced cues that escalation was going to occur and they were being missed. And so we really wanted to provide education on what that escalation cycle looked like for caregivers, and cues for different physiological states that were being missed. When this individual was in pain, there were some physiological conditions that could cause pain. And there were observable behaviors that were being demonstrated, but were nuanced and they were being missed. And so we were able to provide education to all caregivers so that they could respond accordingly. If we go to Y, who was 5 at intake, our focus for intervention was on communication, social skills training, advocacy, and then tolerance of uncertainty or change. We worked on lag schedules of reinforcement, SBT, and then scaffolding support within natural environment teaching. The caregiver focus was on how we frame demands, reinforcing communication right away and not just assuming like, oh, that's easy. Co-regulation and flexibility and expectations. And I am, instead of skipping to the next slide for outcomes so that we have it fresh in our mind, I'll go through outcomes as soon as I go through all the cases here. For C, provider focus during interventions was on advocacy and tolerance of uncertainty and change. We did focus on SBT. We worked on cooperative regulation, skills training. And then our caregiver focus was on demand presentation, co-regulation, and flexibility in the expectations when we're presenting them. And for F, who's 26 at intake, intervention focus was on advocacy and communicating choices, with man training using augmentative communication and shaping that response. And caregiver training has been on demand presentation, modeling communication, and co-regulation.